The following podcast is part of a certified educational activity titled Fresh Perspectives on Moving Toward Personalized Care for Bladder Cancer. Tips, tools, and strategies for leveraging the latest advancements across the disease spectrum. Access the entire activity and complete the post-test at peerview.com/KPE860. Downloadable slides and practice aids are also available.
So good evening. It's a pleasure to have everyone here, and we're excited to move forward with an exciting session on fresh perspectives on moving toward personalized cancer care for bladder cancer, tip, tools, and strategies for leveraging the latest advancements across the disease spectrum. So I'm here with friends and colleagues. I'm Matt Malowski, and I'm here with Shilpa Gupta and Dr. Andrea Necki. So what are the goals for today? The first is to augment knowledge of new evidence supporting therapeutic strategies for bladder cancer management, really across the disease continuum, based on innovative drug delivery approaches, modern immunotherapy regimens, as well as some of the new targeted therapies. Equip you with the skills to implement these approaches into personalized treatment plans for patients with varying stages of bladder cancer, and then to provide guidance on how to support team-based management of the unique suite of adverse events that are associated with contemporary therapeutics for bladder cancer. So to start, there are a number of unmet needs in the treatment of both non-muscle invasive and muscle invasive bladder cancer. In the context of non-muscle invasive disease, only about 1/3 of patients with NMIBC are given intravesical BCG. There have been significant BCG shortages that continue in the United States that have created a major impact on access for patients. For MIBC, close to half of patients with MIBC worldwide may not receive curative intent therapy. And patients who've undergone radical cystectomy for muscle-invasive disease often have some impairment in health-related quality of life. And unfortunately, these patients, in spite of an aggressive approach to management, are still at risk for a high risk for recurrent disease. And so the development of effective, safe, and durable intravesical treatment remains a critical unmet need for patients who would like to avoid cystectomy. And effective approaches post-radical cystectomy are key to lessen the risk of recurrent disease. As I said, the Bladder Cancer Advocacy Network is sort of co-sponsoring this event. If you're not familiar with Beacon, Beacon is an excellent resource, not only for your patients, but also for professionals. Beacon has materials that can be disseminated within your clinic. They have webinars, videos, podcasts, clinical trials dashboard, and other support mechanisms that can assist not only your patients, but again, you in the clinic. So without further ado, we'll begin. Dr. Gupta, who is an associate professor in the Department of Hematology Oncology, the director of Genitourinary Oncology program at the Taussig Cancer Institute at the Cleveland Clinic, is going to speak with us about addressing unmet needs in high-risk NMIBC and MIBC with innovative therapeutic solutions. Thanks, Dr. Gupta.
Thank you, Matt. Thanks for being here. This is the overview of AUA and SEO treatment guidelines for non-muscle invasive bladder cancer. As you all know, patients undergo TURBT for diagnostic purposes, and if they have low or intermediate risk disease, then they are referred for further BCG, which is all managed by urology. If patients have high-risk disease, then there's completeness of resection that needs to happen, and the path report needs to make sure that muscle is present in the specimen so we are not understaging. And a second TURBT within 2 to 6 weeks of initial resection if there's incomplete resection or high-risk tumors. And if patients have had risk stratification and have intermediate risk disease, they undergo a 6-week induction of BCG or chemotherapy or also immunotherapy, which here refers to BCG because there's no immunotherapy approved in BCG-naive disease right now. And then they undergo maintenance BCG. For low-risk disease, they are observed. Muscle-invasive bladder cancer is more of a systemic disease, and we'll cover that later. For high-risk non-muscle invasive disease, also there's a 6-week course of BCG induction followed by maintenance BCG for 3 years. So what is the evidence supporting immune checkpoint inhibitors in high-grade BCG unresponsive disease? The phase 2 Keynote 057 trial, which here was Dr. Neki was heavily involved in this trial. In January 2020, FDA approved the use of pembrolizumab for BCG unresponsive high-risk NMIBC in patients who were ineligible for or elected not to undergo cystectomy. Cystectomy has been the gold standard for patients who do not respond to BCG, but as we can imagine, nobody really wants their bladder out, and we're looking for options for these patients. After a median follow-up of 36.4 months, of the 96 patients who had BCG unresponsive disease, 41% patients had a complete response at 3 months, and the duration of response was 16 months. Of the 39 responders, 46% remained in CR for over 12 months, and 28% remained in CR at the time of data cutoff. There were no new safety signals with pembrolizumab. Another study, which was led by the SWOG cooperative group, Dr. Peter Black, SWOG S1605, similar patient population. The primary endpoint was CR at 6 months with a mandatory biopsy. And the unplanned secondary endpoint was complete responses at 3 months. And they had similar results with 42%. But in the updated results, the response duration of greater than 6 months CR in patients with CIS was 49% at 12 months, and event-free survival in 55 patients who did not have CIS at 18 months was 47%. Notably, this drug is not approved in this indication, only pembrolizumab is. So what's next? There's a lot of interest in further exploiting immunotherapy in these patients. So there's the phase 3 POTOMAC trial, which is high-risk NMIBC with any high-grade, any T1, multiple recurrent and large tumors are allowed, who are BCG naive. So as we move immunotherapy earlier and earlier on to harness the power of the immune system, and there's 3 arms, BCG induction and maintenance for 2 years, BCG induction and maintenance with durvalumab, and BCG induction only with durvalumab. And like Dr. Milowski mentioned, with the BCG shortage, these are strategies to see if we can get by with lesser doses. Phase 3 Keynote 676 is the other trial, which is randomizing patients to BCG versus BCG with pembrolizumab, and primary endpoint is complete response in patients with CIS. And there's a lot of different novel trials that are going on. The phase 2 Sunrise trial is using a novel technology called a pretzel, which is installed in the bladder, and it has a drug in it. BCG unresponsive high-risk NMIBC patients are randomized to TAR-200, which has gemcitabine in it, along with a checkpoint inhibitor setrilimab, which is subcutaneous. And the cohort 2 is TAR-200 alone, and cohort 3 is setrilimab alone, which is a really good way of doing this study to know what each agent is adding. The phase 1-2 ADAPT bladder was, again, BCG unresponsive high-risk disease with multiple cohorts here using durvalumab backbone. Interestingly, there's also a radiation component in cohort 3 to see if that can help in this disease. Traditionally, we don't use radiation for non-muscle invasive disease. And cohort 4 is also adding gemcitabine and docetaxel. The TOR trial is exploiting the use of FGFR inhibitor in patients who have FGFR3 mutations or fusions. It's believed to be higher in non-muscle invasive compared to metastatic setting. Patients will be randomized or are being randomized to erdafitinib or investigator's choice of intravesical therapy. And tomorrow we'll see some updates for the cohort 2 by Dr. Gary Steinberg, and also the cohort 3 for these studies. So in treatment approaches for non-muscle invasive patients who are unresponsive to BCG, there's a lot of research going on. There's the QUILT study, which showed that IL-15 super agonist phase 2-3 QUILT study. In this, the CR was 71%. Notably, this used BCG in addition to the IL-15 super agonist. It was safety and tolerability was comparable to BCG alone. And then there's variety of checkpoint inhibitors that are being tested, FGFR inhibitors, viral gene transfer, the phase 3 Adstiladrin trial. This was a positive trial, and it was recently approved by the FDA for BCG-unresponsive disease. And then there's the gemcitabine and docetaxel, which has shown activity in smaller data sets, and now there's a phase 3 trial called the BRIDGE trial through the ECOG cooperative group. Coming to muscle-invasive bladder cancer, as we know, cisplatin is the only chemotherapy that has shown survival benefit in muscle-invasive bladder cancer for patients who are eligible to receive it. The SWOG trial was the landmark trial, which randomized patients to MVAC and cystectomy versus cystectomy alone, and there was a 2.6-year median overall survival benefit in patients who received neoadjuvant cisplatin. And there's a whole lot of phase 2 trials that have exploited the role of immunotherapy alone or in combination with cisplatin-based chemotherapy or as an immunotherapy doublet. And several of us are involved in some of these trials. Dr. Necki here has really was the first to show in the PURO-1 trial the use of pembrolizumab. We showed a PCR rate of 42%, which is higher than even what you might get with just cisplatin alone. Abacus is another trial with atezolizumab alone. Then there's a durvalumab tremelimumab trial. Nabucco trial used nivolumab ipilimumab. We led the BLAST-1 trial with nivolumab and gemcis. There's other trials with pembrolizumab and gemcis here led by Dr. Milowski. So this really tells us that there's a lot of scope to combine immunotherapy with chemotherapy, and also a lot of promising activity with immunotherapy alone. And we are presenting some updates to the BLAST-1 study tomorrow. So this obviously led to phase 3 trials to see if addition of immunotherapy is better than chemo alone or just cystectomy alone for cisplatin-ineligible patients, which is the current standard. And there's a lot of trials like the Keynote 905, where patients are randomized to pembrolizumab and enfortumab vedotin versus cystectomy. Then there's a cooperative group trial of gemcarbo and avelumab versus upfront cystectomy or nephroureterectomy. It allows upper tract urothelial cancer patients. And Volga trial is durvalumab, tremelimumab, and enfortumab vedotin. For the audience here, enfortumab vedotin is really a very effective agent in the metastatic setting and is being used in a lot of muscle-invasive bladder cancer trials. And for cisplatin-eligible patients, the comparator arm is gemcis alone, and the treatment arm with the novel immunotherapy and gemcis is what most of these trials are using. There's the Energize trial that completed accrual recently, gemcis nivolumab. Niagara trial has also completed accrual with durvalumab and gemcis. And the other trials like Keynote 866 with gemcis and pembrolizumab, and EV304 with pembrolizumab and enfortumab vedotin are still ongoing. Now the next question is, what can we do for patients who don't want cystectomy? And I think in my experience, very, very few patients are really keen to get cystectomy. And there's a lot of emphasis on how can we preserve bladder in these patients with novel treatments and novel drug delivery systems. So like I said earlier, TAR-200 is an intravesical drug delivery system that is shaped like a pretzel, and it releases gemcitabine in a sustained fashion within the bladder. And it increases the dwell time of the local drug concentration, so it's very effective within the bladder. And in the phase 1 study of TAR-200 in patients with muscle-invasive bladder cancer who were unfit for or refused curative intent therapy, this showed activity, and it was safe and tolerated when given after 4 cycles. And there was a response rate of 40% at 3 months, median overall survival of 20 months, and 12-month progression-free survival was 67.7%, which is quite promising. There's a variety of trials going on in combination with the Sunrise program, which incorporates the backbone of TAR-200. For example, in this study, patients who have muscle-invasive bladder cancer and C2 to T4A disease, no nodes or metastatic disease, and not undergoing radical cystectomy, they are randomized to citrilimab, which is a subcutaneous checkpoint inhibitor, and TAR-200 versus dealer's choice concurrent chemoradiation. And this trial is currently ongoing. And then there's the Sunrise 4 trial, which is looking at TAR-200 and sertolizumab versus sertolizumab in patients with MIBC who are ineligible for neoadjuvant cisplatin-based chemotherapy. There's another phase 2 trial called Immunopreserve, which is durvalumab and tremelimumab with concurrent radiation in patients who are not candidates for cystectomy or refuse cystectomy. Patients undergo a maximal TURBT. They're treated with durvalumab and tremelimumab every 4 weeks for 3 cycles, and radiation is given per standard protocol. And then a repeat TURBT is done, and if there's a complete response, patients can preserve their bladder, and if there's no complete response or there's a relapse, then they undergo salvage cystectomy. And the CR in this trial, post-treatment biopsy was in 81%. The signals for safety were not different from previously reported, and there's a lot of other trials going on with these agents. And again, there's another trial led through Hoosier Network where patients received gemcitabine, cisplatin, and nivolumab for 4 cycles. And if they had on clinical restaging a clinical CR, patients could choose between no cystectomy or cystectomy. And this was patient's choice. As you can see, 30 patients chose no cystectomy, only 1 patient chose cystectomy. And if patients did not have a clinical CR, they were offered cystectomy. And in this study, the clinical complete response rate was 48%. So these are just hypotheses generating data, and more trials need to be done. And these are the trials that a lot of us are supporting. The RETAIN trial is looking at dose-dense MVAC based on genetic biomarkers and if patients can preserve their bladder. And the Alliance trial is also addressing that question. If patients have mutations and have a complete response, can they forego surgery? So now we'll discuss a case. Are you discussing?
Yeah, no, that's great.
Yeah.
So that was a super tour through all of what's going on in non-muscle invasive and muscle invasive bladder cancer. And I think it's just extraordinarily exciting for those of us who've been doing this for many years to see how much has gone on in just a few years in terms of the development of new therapies and novel approaches. So this is a patient with MIBC who would like to avoid radical cystectomy, and this is great because there are several questions here that are asking this same question as this case. So this is a 60-year-old woman with a good performance status, ECOG 0, recently diagnosed clinical T2 disease based on a transurethral resection, GFR is 61, has some hypertension but a normal ejection fraction, and the patient has no notable neuropathy or hearing loss. The question here is really, when discussing bladder preservation options with patients, what particular factors or considerations are important when you're sitting down with a patient and having this discussion with a patient who I see all the time who come in and don't want to lose their bladder. Dr. Necki?
Thank you, Matt. Good evening, everyone. It's a really intriguing question provided here. I think that we have 2 different levels of discussion. The first is the first level of discussion takes into account the availability of standard therapies and the availability of chemoradiation as standard of care for patients as a bladder preservation strategy for patients who elect not to undergo radical cystectomy, who want to preserve their bladder. And we do not have seen so far pretty well established criteria for eligibility to chemoradiation as compared to radical surgery. So we can say, okay, I would consider patients with more advanced disease, T4 disease, or patients with predominant or exclusive non-urothelial histology, or patients with hydronephrosis as less candidates for chemoradiation. But there are very empirical criteria that are based on daily practice. There is an additional factor to consider, which is a very novel factor, meaning the availability of clinical trials in this space, as Shilpa has already mentioned, and that provided you an outstanding overview of the available trials in the bladder preservation arena. Here, there may be an additional factor of patients wanting to preserve their bladder without any radical local therapy, including radiotherapy in their bladder. And then many issues and many questions will rise regarding the ways of selecting patients for surgery sparing and radiation sparing approaches.
There's another great question here, and maybe Dr. Gupta can take this one. So a patient with BCG unresponsive disease, BCG who is unfit for surgery, what are the sort of things that you think about for that patient? And obviously, you presented some really exciting work with some new therapies.
So that's a great question, Matt. As you know, these patients are seen by urologists, right? So, and the gold standard has been cystectomy. So, unless the patients really voice their opinions of not wanting a cystectomy, which in case is the case, and if the urologists are willing to offer alternative therapies like pembrolizumab, that is currently approved in this setting. We just saw the data from Keynote 057. But I think these are not the patients who are coming to us directly. I've had only a couple of patients who read up about it and come because it was not offered to them, and that's the only time we are seeing these patients as direct referrals, and we certainly offer it.
Yeah, I've had the same experience. I mean, I think that we see a few patients who come in for immunotherapy, but fortunately there are many other therapies, as Dr. Gupta alluded to, that are currently in the context of clinical trials, and I think heading toward approval that are really going to transform the landscape of patients with BCG unresponsive disease and give patients an opportunity to hopefully go on to retain their bladder. There's studies and interesting data from the RTOG looking at radiation therapy in combination with chemotherapy in high-grade T1 disease. So I think that things are really coming down the pike quickly, and hopefully this is, again, going to transform the field. So I'm going to take it from here and talk about the status of adjuvant therapy for muscle-invasive bladder cancer. I practice at the University of North Carolina at Chapel Hill, and I'm privileged to work with some wonderful urologists and radiation oncologists and others, and we actually practice in a multidisciplinary way, which makes the discussions and the care of patients with bladder cancer much easier. I'll start with a case. So this is a patient who undergoes radical cystectomy after chemotherapy. It's a 65-year-old woman with good renal function and ECOG performance status. Cystoscopy and imaging consistent with a sessile mass at the anterior bladder wall. The diagnosis of localized muscle-invasive bladder cancer is made. Patient doesn't have any neuropathy or hearing loss or evidence of congestive heart failure, so is a candidate for cisplatin-based neoadjuvant chemotherapy, as Dr. Gupta discussed. So the patient goes on to receive 4 cycles of gemcitabine and cisplatin. They have a radical cystectomy and pelvic lymph node dissection with a neobladder, and the pathology, unfortunately, shows persistent muscle-invasive disease with YPT3A N0. And so we'll come back to this case after our discussion. And so there've been some trials looking at adjuvant immunotherapy in patients with muscle-invasive disease with PD-1, PD-L1 inhibitors. The first 2 trials have reported out. The third trial has not. So the IMvigor10 trial randomized patients to atezolizumab versus observation with a primary endpoint of disease-free survival, and unfortunately did not meet the DFS primary endpoint. The CheckMate 274 study, which was designed somewhat differently, it used a placebo, randomized patients versus the anti-PD-1 agent nivolumab with a primary endpoint of DFS, and you can see the secondary endpoints here. And here, this did in fact show an improvement in disease-free survival and was approved by the FDA in August of 2021. And finally, the Ambassador study, which is being done through the National Clinical Trials Network, led by a colleague, Andrea Apollo, has randomized patients to pembrolizumab versus observation. This trial actually had co-primary endpoints of DFS and OS, and we are awaiting the results of the Ambassador trial, which some call the potential tiebreaker. So here is the Kaplan-Meier curve from the IMvigor10 study. Here atezolizumab again versus observation. You can see here that this is a very negative study, no DFS benefit seen. When looking at the CheckMate 274 study, this is updated DFS data, and Dr. Galsky will be presenting extended follow-up in a late-breaking abstract. Here in the intent-to-treat population, the hazard ratio was 0.70. You can see the median DFS for nivolumab at 22 versus 10.9 months with placebo. And it was also positive in the PD-L1 greater than equal to 1%, and this is tumor membranous staining using the 28-8 assay by DACO. And this also showed an improvement in disease-free survival with a hazard ratio of 0.53. So again, both of these, in both populations, positive for disease-free survival benefit, although we don't have overall survival data at this time. When looking at Checkmate 274 from a safety standpoint, I think that all of us that have used immune checkpoint inhibitors quite familiar now with the potential toxicities. I think that this speaks to that, the typical pruritus, fatigue, diarrhea, rash that one sees. I think in general, if you look at the common sort of grade greater than or equal to 3 select treatment-related adverse events, this is pretty manageable. And if you look at treatment discontinuations, I think patients were able to stay on treatment. Here's health-related quality of life data in both the ITT and the PD-L1 selected population, demonstrating that there was no deterioration in health-related quality of life, which I think is particularly important when we're looking at perioperative therapy trials, particularly in the adjuvant setting for patients, where we know that we are going to overtreat patients until we have the perfect biomarker to be able to select patients better. This is some exciting work by Dr. Necki that was shown to look at a series of different potential biomarkers, tumor immune features associated with disease-free survival in this study, looking at interferon gamma gene signature and CD4 gene expression, predictive of clinical benefit, a positive prognostic association between CD8 infiltration and DFS, a positive association between TMB and DFS, and there's going to be future studies to look further at these potential biomarkers. I will say that there's been a lot of differences in terms of what these particular biomarkers have shown in other studies, but these have used different checkpoint inhibitors. They have been in different clinical disease states, and so there are many variables that ultimately confound the ability to use these biomarkers across the entire spectrum of patients with bladder cancer receiving immune checkpoint inhibitors. What about ctDNA? So this has been particularly exciting. ctDNA has obviously demonstrated some very promising results in diseases like colon cancer. This is data that was initially presented by Dr. Powles and ultimately published in Nature, and essentially showed the predictive and prognostic value of ctDNA. So this was from the IMvigor10 data, and you can see here that the patients, when looking at DFS and OS, who had negative ctDNA did much better than those patients who had positive ctDNA. And here, with regard to the treatment that they received, here again is our negative ctDNA patients, and this is DFS, this is OS, and once again, here you see this is the ctDNA positive group, and these patients appear to have a benefit associated with the use of atezolizumab in the adjuvant setting. And so there's an exciting study that's ongoing. There's other studies that have planned looking at patients with high-risk MIMBC and looking at this question of ctDNA. So this is the IMvigor11 study, which is using ctDNA, and then those that are positive, randomizing them to atezolizumab versus placebo, and those that are negative receive standard of care outside of a study. So hopefully we'll have some more answers with regard to the potential role of circulating tumor DNA in patients with bladder cancer in the adjuvant setting. So a patient undergoes radical cystectomy after chemotherapy. So this is our patient with YPT3A and 0 disease. So here there is not a role for adjuvant chemotherapy in this particular patient. There's not a clear benefit that's associated with using any alternative chemotherapy in this setting. That Dr. Grupa explained, it's really cisplatin-based chemotherapy that confers that survival benefit in patients with bladder cancer, both in the neoadjuvant and perhaps with less robust data in the adjuvant setting. And based on the results from Checkmate 274, adjuvant nivolumab is certainly reasonable. The eligibility for that trial in patients that received neoadjuvant chemotherapy, if they had persistent muscle-invasive disease, they were potential candidates, and in those that did not receive neoadjuvant chemotherapy, they needed to have PT3 and/or node-positive disease. Adjuvant nivo can be offered also for patients ineligible for or who decline cisplatin-based chemotherapy, as the way the study was designed. So I mentioned the idea of multidisciplinary care, and at our site, and I know at many others, this is a part of the process in seeing patients with bladder cancer. As an example, at our site, all patients with muscle-invasive disease are seen by urology, radiation oncology, and medical oncology. There's equipoise when we see patients with regard to trimodality bladder preservation approaches and radical cystectomy in those carefully selected patients that Dr. Necki mentioned. But I think there's, with all of these advances that have occurred over the last few years, translating these findings into real-world practice requires careful planning, discussion, and coordination in multidisciplinary care teams. I mean, here we are, medical oncologists. Dr. Gupta gave a fantastic overview on non-muscle invasive bladder cancer. I think that's really telling about how important it is for all of us to interact in the clinics in managing our patients. And this is only going to become more and more important as we develop more therapies in the NMIBC space, both with radiation oncology, medical oncology, and again with urology. So building those relationships, I think, is important, developing multidisciplinary care clinics, and this is only going to help to move the field forward. So moving on, unmet needs in the treatment of metastatic urothelial cancer, there are many, unfortunately still, in spite of the progress that we've made. More than half of patients may not receive first-line systemic treatment. We all know that clinical trial enrollment is not just a problem in urothelial cancer, it's a problem across the board in oncology, and we need to do better. We certainly need to do better in terms of serving our underrepresented populations and ensure that they participate in clinical trials as well. Many patients who progress on first-line or second-line therapy do not receive subsequent treatment. And post-immunotherapy treatments vary widely and often include chemotherapy or a different PD-1, PD-L1 inhibitor, really rather than using a novel agent. We have a lack of data for sequential strategies, and this is very complicated because the way in which the studies have been designed don't allow us to answer the questions of how do we sequence these agents best. And so chemo, IO, ADCs, FGFR inhibition, and these others are going to come down the pike really quickly. And again, we struggle with sequencing. Patients who may have neurotoxicity with one drug going on to receive another drug that may be associated with neurotoxicity. So we have to learn how best to sequence these agents to be able to provide therapies in the right way at the right time to the right patient. If adjuvant IO becomes standard, how does this impact therapy selection if metastases occur thereafter? What is that window before you may want to consider using IO again? This is certainly being done in the context of studies, but the truth is we really don't know that answer. And so some random time points have been chosen to be able to decide when IO may be reasonable again. Another slide just to bring us back to Beacon. This is, again, a wonderful organization. They have a clinical trials dashboard, which can be really helpful to find a trial that fits an individual patient's need. The doctors can save trials. They email them to patients for further discussion at their next visit. It's a much more friendly system for looking at clinical trials than going to nci.gov. So hopefully you'll head over to the Beacon site and take advantage of some of these resources that are available. So this is a patient progressing with metastatic urothelial cancer. This is a 69-year-old man with symptomatic progression. He's got fatigue and back pain after 4 cycles of gemcitabine and carboplatin. The CAT scan shows liver and bone metastases. ECOG performance status is 1. Receives immunotherapy after chemotherapy consistent with guidelines. The next generation sequencing is done, and the bladder tumor tissue does show an FGFR3 S249C mutation. Patient has no autoimmune, eye, skin, nail, or GI issues. Hemoglobin's 10.2, albumin 3.6, hemoglobin A1C is 9.2. Has some grade 1 neuropathy from diabetes. Patient's also obese. So these are the sort of patients that we see in the clinic. So how do we, again, take that clinical trial data and bring it to the clinic and being able to manage our patients? And so we'll come back to this case. So next I want to introduce my colleague, Dr. Andrea Necchi, who's going to speak to us about refining therapeutic options in metastatic urothelial cancer. How can we best personalize care? Dr. Necchi is an associate professor at San Raffaele University, the director of genitourinary medical oncology in Milan, and has done really a tremendous amount of work and has a tremendous body of work that he's part of in leading the field forward in bladder cancer. Thanks, Dr. Necchi.
Thank you, Matt, for a nice introduction. Welcome everyone again. Good afternoon, good evening. So let's jump to the arena of patients with local advanced or metastatic disease. So this is just a snapshot of the achievements in the last 10 years, I would say, made in the urothelial bladder cancer with the advent of newer trials, newer agents, primarily represented by immune checkpoint inhibitors, and later on represented by novel agents like targeted therapy or ADCs. This is a slide which was not yet available till quite recently, meaning that we have still so many available options for treatment in these patients. So we have a rising problem of rising difficulties in trying to establish a right path for these patients, in particular, as Matt has already mentioned, in terms of the right sequencing of these therapeutic options in patients developing metastatic disease. Also based on the developments that is ongoing in patients with early disease setting that may somehow have an impact on later stages, and the attrition rate of immunotherapy and other novel agents is still impacting the later stages. The current management of metastatic urothelial bladder cancer is shown here, and is basically recapitulating the recommendation that are published by major guidelines like ESMO guidelines or EAU guidelines. So we are clearly a first separation of the path for cisplatin eligible and cisplatin ineligible patients. For cis ineligible patients, we have still a role for frontline checkpoint inhibitors in PD-L1 positive tumors. And we do have already a special category of patients who are judged as being platinum ineligible, and Shilpa has worked a lot in trying to establish a consensus definition of platinum ineligibility, for which the upfront immune checkpoint inhibitor should be indicated. Then, after maintenance immunotherapy or second-line immunotherapy, there are further therapeutic options, mainly represented in second or later line setting by targeted therapy, and erdafitinib was the first targeted agent approved in patients with urothelial cancer, and then the ADCs, primarily represented by enfortumab velotin, jumping into the therapeutic options in patients who have already experienced any chemotherapy and immunotherapy agents. The point here is how to best select, and we will see, and we will discuss about this later in my presentation, how to best select patients for one treatment option versus another one, in particular in patients with the evidence of any genomic alteration that may portend the use of targeted therapy. But of course, we have experienced the initial failures in clinical trials, in the drug development, in the strategy development in metastatic patients. In particular, all the attempts of trying to use the backbone chemotherapy represented by platinum and gemcitabine chemotherapy, and to move towards this combination therapy by providing a third drug represented by an immunotherapy agents, have failed to provide significant results and significant advances or clinically meaningful advances for the patients, with the only exception represented by the PFS data in patients enrolled in the IMvigor 130, a trial with atezolizumab plus chemotherapy versus chemo and placebo, The overall survival was not met, and we do have updated results, and will have updated results tomorrow in the oral abstract session, providing additional follow-up data from this trial. And all the remaining trials that are following the same line, the same path of including an immunotherapy agent in combination therapy, have failed to meet the primary endpoint of OS, or either OS or progression-free survival. The only exception being represented by a completely different strategy, represented by the sequential therapy of chemotherapy first and boosting responses with immune checkpoint inhibitors as maintenance therapy, in particular represented by avelumab therapy in the Javelin Bladder 100 trial, and we will see the trial details later on. The other failure of clinical research in this disease is represented by the identification of suitable biomarkers to best select patients as right candidates for selected therapies, frontline or in later line therapy. This is just a snapshot of the available data presented or published for the major trials, the major phase 2 trials that you have seen in previous slide. The data raise a lot of controversy with regards to the role of PD-L1 expression, or the tumor mutational burden assessment, or the combination of the two. We have positive data or trending positive data, for example, with the combination of PD-L1 expression and TNB in patients treated with atezolizumab monotherapy in the IMvigor 130. Data were not confirmed in the combination chemoimmunotherapy arm. We do have a role for blood tumor mutational burden as potential way of selecting patients for PD-1 or PD-L1 agents and CTLA-4 targeting in the Danube study. But these are pretty unique data, still not reported in other similar studies. And we have quite negative data regarding PD-L1 expression and TNB from Keynote 361 study investigating pembrolizumab and chemotherapy. The only exception being represented by the response to treatment as a surrogate, as a sort of a clinical biomarker to select patients as suited candidate for achieving a long-term benefit with, in particular, with single-agent immunotherapy. And data gathered from frontline trials, in particular from frontline pembrolizumab trials, reported the patients the few patients achieving a very good partial responses or complete responses were endowed with long-term maintained responses with long-term follow-up. This is something that is relatively new in this disease, and is actually recapitulating the original data presented, for example, with high-dose IL-2 in renal cancer. So the possibility of achieving something that is close to the cure in patients with far advanced disease receiving frontline systemic therapy. It is exciting, but of course it's about a very few proportion of patients achieving outstanding response. I have mentioned the Javelin Bladder 100 study, the switch maintenance study, maintenance avelumab plus best supportive care versus best supportive care alone in patients achieving at least a stable disease to frontline platinum-based chemotherapy. The study met all the primary and secondary endpoints with a clinically meaningful and statistical significant improvement in the overall survival, in progression-free survival, in the response rate, on so many other endpoints, and setting a new standard of care in the United States, as well in the European Union and worldwide, in many other countries, in patients with metastatic disease. The question is for the frontline therapy is for example the potential role again for CTLA-4 targeting as for the combination therapy in patients with metastatic disease, and the phase 3 NILE study is likely to set a final word on this. It's a phase 3 study testing durvalumab in combination with chemotherapy, or durvalumab and tremelimumab in combination with the platinum-based chemotherapy chemotherapy versus platinum-based combination therapy alone as a standard of care, and the data readout will occur quite soon and will set a role for the combination therapy. So let's jump down to the approaches in patients without any selection according to biomarkers. What can we do what are the therapeutic options in patients who have already received chemotherapy, immunotherapy, but whose tumor is not endowed with special gene alteration to be targeted by targeted therapy. And so we open up the door to the ADC arena, and in particular to the enfortumab vedotin as the primary antibody drug conjugate to be tested in this and to provide data, significant data in the urothelial cancer space. Enfortumab vedotin is an ADC targeting Nectin-4 protein, and with the payload, which is called monomethylauristatin E, which is a microtubule disrupting agent. And the EV was evaluated in phase 2 and phase 3 study, EV201 and EV301, provided outstanding response rate as single agent, as monotherapy in patients in third line or later line. And the data from the phase 2 have been confirmed in the phase 3, EV301, investigating EV monotherapy versus the investigator choice chemotherapy, and providing clinically meaningful and statistically significant improvement in overall survival and setting a new standard of care for patients who have already experienced chemotherapy and immunotherapy in the US by FDA, as well as in Europe by EMA. Of course, the drug is not definitely without any side effects, because we do have special side effects to consider when managing manageable drug in general, like ADCs. In particular, for enfortumab vedotin, we do have the red cutaneous rash to consider as potentially meaningful side effect, peripheral neuropathy, and other special side effects, like in particular hyperglycemia, to be considered for these patients. Meaning that also for agents like ADCs, we do need the multidisciplinary and multi-specialty discussion ideally prior to start therapy. And in this case, the help of dermatologist and help of the endocrinologist will play a substantial role in benefiting patients with a higher quality of life and higher compliance to treatment when managed since the very beginning with other specialists. Another ADC that provided data in the same patient population, chemo-treated and immune-treated patients, is sacituzumab govitecan, which is targeting a different protein, which is called TROP2, and which is characterized by a different payload, which is called SN38, which is basically a metabolite of irinotecan. The sacituzumab govitecan monotherapy has been investigated in the TROPiU-01 platform, which is including different cohort of patients in different disease settings. The objective response rate in patients in third line was 27%, so a bit lower as compared to enfortumab vedotin, but in any case quite compelling compared to the benchmark chemotherapy. And the drug is still being evaluated in the phase 3 study, the TROPiCS-04, which is comparing sacituzumab govitecan monotherapy versus investigator choice chemotherapy, a quite similar design as EV301. And the study is still ongoing, recruiting patients, and we will see what the data will look like in the near future. Again, here we have an issue of safety, and the safety profile of sacituzumab is quite a bit different from that of enfortumab vedotin. Here, the major problem may arise with respect to neutropenia, so hematological problems, and diarrhea. So the typical side effects of irinotecan, for which GI oncologists are pretty well aware, and of course this problem may be huge if not managed adequately since the very beginning for bladder cancer patients. So again, here the need for multidisciplinary evaluation since the very beginning, multi-specialty evaluation since the very beginning of this patient. There are additional ADCs that provided initial, very early results, in particular in combination therapies, in combination with immune checkpoint inhibitors. There may be a revised role for HER2 targeting in bladder cancer, in particular with the use of trastuzumab deruxtecan, which is targeting HER2 in bladder cancer. And the data from the phase 2 study combining trastuzumab deruxtecan with nivolumab have been provided in a few patients, and the response rate is compelling, even though it's still not so outstanding as with enfortumab vedotin. In particular, and considering the fact that we are dealing with a combination therapy, so we still lack suitable biomarkers to identify the contribution of the two drugs over the objective response rate overall. And of course, we should consider the fact that the safety signals are not so easy to manage in general for patients that are generally frail, maybe sometimes quite frail, and in this case represented by grade 3-4 events reported in 40% of the patients in this phase 2 study. We do have already the sacituzumab pembrolizumab initial data from the same TrophyU01 platform in patients in second, third line therapy, and the objective response rate is pretty much overlapping to the previous study, 34%. Again, here the same issues, same problems in trying to reading this data and to setting this data into the stage of the available options today. And the future options for these patients is still a matter of intense debate and intense research. Much more robust data, much more compelling data, I would say, have been reported with the combination of enfortumab vedotin and pembrolizumab, in particular with the EV-pembro combination as frontline therapy in patients with metastatic urothelial cancer who were ineligible for cisplatin chemotherapy. The EV-103 is a similar platform design as TrophyU01, and the cohort K actually included patients in frontline, cis-ineligible, and the objective response rate reported at the ESMO last year was outstanding, 64.5%. This is something that was not conceivable until quite recently, certainly not with the standard platinum-based chemotherapy or similar agents. Also considering the fact that the treatment was characterized by special side effects, but overall the treatment was well tolerated, and the rate of the grade 3-4 adverse event were acceptable. And on the right side, you can see the waterfall plot showing the depth of response of the vast majority of the patients. So we will see what the future of this combination therapy will look like in the near future. And there are phase 3 studies ongoing testing EV-pembro combination as frontline therapy in cis-eligible patients, and the same combination also, as Shilpa has mentioned, in the neoadjuvant setting prior to radical cystectomy in cisplatin-eligible patients. So we will see whether the combination and these outstanding results will be confirmed in earlier disease settings, even early disease settings, and if, in particular, enfortumab vedotin will become the next backbone chemotherapy to be combined with immune checkpoint inhibitors, and potentially in the near future with other novel therapies as compared to the standard platinum-based chemotherapy. So when looking at the data overall from the ADCs, one of the reasons that may explain partly the different activity of the drugs may be related to the payload. Because in general, based on the data that are available so far at least, all the ADCs delivering the MMAE as a payload provided more promising results compared to different payloads. So this may mean that the chemotherapy agent that we are using as backbone therapy, in particular in combination therapy with immunotherapy, may play a huge role here in determining the outcome and the efficacy of these neuroagents. Of course, I have mentioned the point of the biomarker. The biomarker identification for neuroagents like ADCs, it's very infancy. It's at the very beginning. We have quite interesting data from German colleagues providing the evidence that there may be a significant difference in Nectin-4 expression between the primary tumor and metastatic sites, with lower expression in metastatic sites as compared to the primary tumor, and also reporting a higher efficacy of EV monotherapy in patients with whose tumor was more intensively expressing Nectin-4. These data, quite original, quite novel, but unique as insofar, may portend a future path for the development of EV, at least as monotherapy, in particular in earlier disease setting. And we'll see if combination therapy will change. The combination therapy, for example, EV pembro, will change the scenario, also the associated biomarkers of efficacy and potential biomarkers of safety of the drug in these patients. What about the therapeutic approaches in biomarker-selected patients? What does it mean, biomarkers selected in bladder cancer? Basically, it means FGF receptor alteration. Even though we have already gathered some important data from different biomarkers targeting, like HRR genomic alterations, and the PARP inhibitor story is summarized here in brief in this slide. There is one study of the Bayou study from the Memorial Sloan Kettering with the durva olaparib combination, so a combination with the immunotherapy and the PARP inhibitor as frontline therapy in cis-ineligible patients, and two smaller studies that use the PARP inhibitors as maintenance strategy after response to frontline chemotherapy. The data overall and the message overall, I would say, is summarized here. HRR gene alteration may be used to select patients as right candidate for PARP inhibitors, at least based on the data reported by these trials, and in particular the combination with immunotherapy, which is endowed with at least partly similar biomarkers of response represented by HRR gene alteration, may be a way to move forward with these targeted agents, at least in bladder cancer. The PREVAIL biomarker study is an observational study trying to collect clinical and biomarker data in patients receiving frontline therapy in the United States. These data are being accumulated and the study is still ongoing. The preliminary data have been presented in a poster session last year at the ESMO meeting, providing a snapshot of the frequency of PD-L1 assessment and PD-L1 expression in the patient starting frontline therapy, showing that a minority of the patients, just above 25% of the patients, actually receive any kind of PD-L1 assessment prior to start frontline therapy, which is pretty surprising based on the fact that we are here in the United States, where there is a label for immunotherapy in PD-L1 positive tumor, frontline, while the rate of positivity of PD-L1 in this patient, so in real world patients, recapitulates the rates reported in major trials in a frontline setting. So very preliminary data that put the initial hints towards the difficulties and the data that may be gathered from the real world practices that are very, very important to accumulate in parallel with clinical trials. FGF receptor alteration are present in about 20%, 15-20%, or a bit less, in metastatic urothelial cancer. more frequent in early disease stage, much more frequent in non-muscle invasive, high-grade non-muscle invasive disease. But we are here targeting this special population, patients with the metastatic disease. So BLC 2001 study was a pivotal phase 2 study of erdafitinib monotherapy tested at different dose levels in patients with the metastatic urothelial cancer who had already received chemotherapy with or without further immunotherapy, and resulted in the approval of erdafitinib by the US FDA as monotherapy in patients with select FGF receptor 2 and 3 genomic alteration, based on very promising data regarding overall response rate of 40%, median PFS and median OS that are shown here. Of course, there is still an issue regarding the role of biomarkers, and we will discuss later on the test and the type of assay to use in order to test this biomarker presence, and the data related to different agents targeting FGF receptor alteration. Erdafitinib the erdafitinib data are being validated in the Thor study, which is a phase 3 study evaluating erdafitinib as compared to investigator choice chemotherapy or pembrolizumab according to the previous treatment as second or third line therapy in patients with metastatic urothelial cancer and suitable genomic alteration. So this study is still ongoing and will set a final role for erdafitinib as monotherapy in selected patients with advanced disease. There is still initial data with combination therapy with immunotherapy and targeted therapy. The North study is a phase 2 study testing erdafitinib and cetrimimab combination frontline compared to erdafitinib monotherapy in patients with the biomarker selected tumors. Erdafitinib monotherapy as compared to erdafitinib and cetrimimab data are summarized here. The point here is that there is clearly an improvement with combination immunotherapy with the outcome data and the activity data in terms of response rate in particular, but at the same time there is a worsening of side effects to consider in these patients because the grade 3-4 treatment-related adverse events were being reported in 50% of the patients as compared to 38% with monotherapy. So safety is still an important issue to consider throughout the therapeutic journey of these patients in parallel with the efficacy data. It's always to be considered as an important endpoint when trying to select in patients for the right treatment, for the right combination therapy, for the right monotherapy in either treatment line throughout the disease course and treatment course of the patients. And of course, regarding toxicity, we do have special toxicity to consider with the erdafitinib use, in particular hyperphosphatemia, which is a targeted effect of FGF receptor inhibitors due to the targeting of FGF receptor signaling in proximal renal tubule. And we do have ocular toxicities, retinopathies in particular to consider in these patients, meaning that again, as I mentioned with the enfortumab vedotin, again here we do need the help of other specialists because we as oncologists are frequently unprepared to best manage a patient developing serious side effects of this kind. So there is clearly need to manage patients since the very beginning with the multi-specialty approach, also in the case of erdafitinib, in particular with different specialists as compared to enfortumab vedotin. So here we should be brave enough to select our partners when starting use of erdafitinib or starting use of erdafitinib, and in the future with starting use of any other novel therapy. So we need the help of other colleagues. Regarding the biomarkers, we are still at the beginning of our path for the identification of the most suited biomarkers for targeted approach. We have huge problems in identifying the best way and the best timing to assessing FGF receptor genomic alteration. Here is the data from the Foundation Medicine dataset comparing liquid biopsies and tumor biopsies in terms of frequency of FGF receptor genomic alteration. In red, you see the difference in the frequency of genomic alteration as compared to when look at as compared to the timing between the tissue-based assessment and the liquid biopsy. So with increasing timing, you see increasing difference between liquid biopsy and tumor biopsy, meaning that patients jump into very later line of therapy to a potential novel therapy like erdafitinib should be tested ideally with a liquid biopsy or a biopsy performed just before starting therapy rather than relying upon I don't know, radical cystectomy samples or TURBT samples of years ago. We do have data also looking at the landscape of genomic alteration besides FGF receptor alteration. This is again a study looking at the Foundation Medicine dataset, including bladder cancer patients, including glioma, including cholangiocarcinoma, showing that patients with FGF receptor genomic alteration will also endowed with the other potentially suitable alteration like alteration in CDKN2A and B genes. We do know that TP53 and retinoblastoma 1 alteration were mutually exclusive. So the most common alteration of FGF receptor is the short variant alteration rather than rearrangements or fusion of the genes. So looking at the landscape of the overall mutations or other potential biomarkers associated with the single FGF receptor alteration could be quite helpful for us in identifying the next step for the development of FGF receptor inhibition in this disease. We do have intriguing data reporting quite different overall response rate with different FGF receptor targeted agents. You can see here that erdafitinib sets apart as compared to the other FGF receptor inhibitors, whose response rate is lower or approximating 25%. And we will see tomorrow the newer data of another FGF receptor, anti-FGF receptor drug, which is called derazantinib, setting a response rate of less than 10%, so failing to meet the end point of being further evaluating this disease. So we do have important data, but seen so far, these data are confined to the erdafitinib development and not to other developments. So the genomic testing discussion is still a growing debate, is still a growing process with the specialists and with patient sites. Eligibility to FGF receptor inhibition, and the right patient who require FGF receptor testing is something to consider. Options to include the specific testing for FGF receptor inhibitors, for FGF receptor genomic alteration as compared to more comprehensive tests like the Foundation Medicine panel is still another issue to consider. Meaning that both urologists and oncologists and other physicians dealing with bladder cancer patients should be involved in all this discussion, trying to best improve the management strategy in general of biomarker role, of FGF receptor alteration role in these patients.
So thanks, Dr. Necchi. That was an excellent overview of the current state of metastatic urothelial cancer. So going back to this case here of this patient who has progressed after chemotherapy and immunotherapy, and they have an FGFR3 S249C mutation. I'll put this patient case to both of you. So we talked about the issues with sequencing and how the data has left us with limited information with regard to how to sequence. Dr. Gupta, how would you manage this patient? What sort of discussion would you have with this patient in the room about potential therapies?
So this patient has had prior platinum, progressed, had immunotherapy, has the FGFR3 mutation, like Dr. Necchi said. Erdafitinib is an option, but so is enfortumab vedotin. So now how to decide what to do is all based on patient-related factors. So this patient has diabetes, which is uncontrolled glycosylated hemoglobin of 9.2, also grade 1 neuropathy from diabetes. So I would be very hesitant to use enfortumab in this patient right now. Start with erdafitinib, monitor closely. Retinopathy is also common in diabetics and also with the erdafitinib, so we need to be really cautious, but get diabetes under control, try erdafitinib, and then if needed, try to use enfortumab later, because this patient has a high likelihood of bad toxicities.
Thanks, Dr. Necki.
There are pros and cons or either options because as regards clinical factors, there is clearly a path to a better use of erdafitinib because of the same issues that Shilpa has already mentioned regarding pre-existing neuropathy or diabetes, and also when considering the biomarker. We should be more in favor of erdafitinib use, but there are still huge debates regarding, for example, in this case, the reliability of FGF receptor alteration found in the primary bladder tumor in patients coming to our clinic with metastatic disease who had already experienced chemotherapy. So things that may have changed substantially regarding the biology, the underlying biology of this tumor. So I would not be so happy to use this information prior to start erdafitinib. I would, for example, personally, I would try to confirm the presence of this alteration with a liquid biopsy prior to start erdafitinib, and in case of liquid biopsy test negative, opting for enfortumab vedotin.
Thanks. Yeah, no, I think this is a complicated discussion with the patient in the room, particularly when the level of evidence of the data is quite different for the use of enfortumab and erdafitinib. But that being said, I think the sort of comorbidities of the patient are pointing one in a particular direction. But I do think that, fortunately we have a bunch of options here. How does sacituzumab govitecan fit into this sort of patient? I mean, when do you begin to think about sacituzumab? Dr. Gupta?
So my practice is to use enfortumab first, primarily because of the data Dr. Necki showed. It has confirmatory overall survival benefit in a phase 3 setting. Sacituzumab can be used before or after enfortumab, but our practice is to use enfortumab first because of level 1 evidence. Again, sacituzumab has a lot of toxicity, as we saw, right? I mean, this patient is at high risk for getting neutropenia and diarrhea, which are both black box label warnings. So no matter what we use for this patient, have to be really cautious and control the other comorbidities and monitor closely.
Dr. Necki, would you follow a similar paradigm here?
Yeah, I totally agree. In particular, a patient presenting with the NIGO performance status of 1 are less candidate to me to sacituzumab govitecan as compared to enfortumab vedotin. Yeah.
Great. So we've got a bunch of really good questions here, speaking to a lot of the discussion that's had from Dr. Necki, myself, and Dr. Gupta. There's one question that I really like, and I'll frame it in this way. The Cancer Genome Atlas disclosed the fact that there were rich genomic alterations in urothelial cancer, particularly as compared to other cancers. And I think at that time, there was a tremendous amount of excitement about the use of targeted therapeutics to hit those specific genomic alterations within those tumors. And then, of course, came immunotherapy, and that sort of fell off the map for a while. And I think in some ways, we're a little bit back where we started with regard to looking at some of these targeted agents. So with that framing, there's a question here which asks, do you think we will have a biomarker that helps guide metastatic urothelial carcinoma treatment in the future beyond FGFR? Are there any that are particularly exciting that you're keeping an eye out for? Dr. Necki?
Yeah, it's a $1 million question, of course. I will start first with the primary issue of availability of this test worldwide. So raising the issue of disparity in access of the patient to this kind of a test in their therapeutic journey, because we are just dealing with the minority of geographical regions in which we do have the possibility of testing patients for this kind of genomic alteration. This should be said first as a primary limitation of this pathway. Second, we certainly have promising data also reported with their two alteration of EGFR alteration. We will present tomorrow the data from the Foundation Medicine Platinum Health database regarding CDH1 genomic alteration in bladder cancer as a potential newer biomarker for immunotherapy response frontline. But again, not so robust data to be translated in the clinic, and of course data that are very hugely biased by unavailability of this kind of approach worldwide, and by lower data and the poor data from the clinical data standpoint.
So we all got really excited about the potential for combination chemotherapy and immunotherapy in patients with metastatic disease, and of course then came Javelin 100, which really transformed the paradigm for patients with metastatic disease to use chemotherapy followed by maintenance immunotherapy, which we've seen to be effective in other diseases as well. There's a question here that specifically relates to other potential maintenance approaches, and you pointed out a few with regard to some PARP inhibition, but any others that we should be thinking about, Dr. Gupta?
Yeah, so Matt, we are leading the main CAP trial through the Alliance Cooperative Group, which is building upon the Javelin Bladder 100 trial, how to intensify the good effect we see with avelumab. We are adding a VEGF inhibitor, cabozantinib. So this is basically a phase 3 trial randomizing patients to avelumab versus avelumab and cabozantinib with the primary endpoint of overall survival. And this trial is currently active, so would urge the audience to support it at their sites.
That's great. Yeah, and that was perfect because Dr. Gupta is the PI for that study, and so it's a super study, and hopefully those of you who have the opportunity to open that study and can put some patients on. I think that'll help us to answer a really important question. There's a question here which I can take, which is, what do you tell patients, or what tips do you give patients when you choose to give them adjuvant nivolumab? So I think this is a difficult question. In fact, the three of us were discussing this before this session began. I think there's several potential points to consider within that question. One is the endpoint. The primary endpoint for the study was, as you're aware, disease-free survival. There was a disease-free survival benefit. This drug was approved. Are there potential patients that, are those that you might discuss this sort of more heavily in the room? I think, we certainly know that patients who receive neoadjuvant chemotherapy, who then go on to radical cystectomy that have persistent node-positive disease, those patients, if you look at 5-year survival outcomes, are close to zero. So I think certainly in patients with high-risk disease, post-neoadjuvant chemotherapy and radical cystectomy, offering them some form of therapy, and here, clear, we have a disease-free survival benefit. I think that, it is a nuanced discussion with the patient, for example, for those that may not have received neoadjuvant chemotherapy and have, for example, T3 disease. I think the risk-benefit needs to be discussed, the absence of a survival benefit at the moment. Hopefully we will see that data down the road. The health-related quality of life is helpful, but as we all know, sort of when you look at global health-related quality of life, it does lack some sensitivity. But I think that a thorough discussion of the potential side effects associated with immunotherapy, again, in someone who otherwise may be cured, who can potentially be damaged by immunotherapy, is really important. And those are long discussions to have with a patient in the room. Any additional comments related to that?
Yeah, I think that there is still a remaining point regarding the role, for example, of immunotherapy as an adjuvant therapy in patients with PT2 disease without any neoadjuvant chemotherapy. These patients are usually excluded, have been excluded from the phase 3 studies with adjuvant immunotherapy, and have been also excluded from trials with the adjuvant chemotherapy, historically the ORTC study. So we do not have, paradoxically, data from chemotherapy and the immunotherapy trials in the PT2 patient population. So there is still a role for investigating on more comprehensive approach, including fewer categories that are still out of data from clinical trials. And we should also consider at the end the fact that if you look at the disease-free survival or progression-free survival data from the ORTC study, chemotherapy upfront versus chemotherapy at the time of disease recurrence, the data and the hazard ratio was quite similar to the data from the Checkmate 274 study and did not translate in overall survival benefit. And we are still now considering the adjuvant chemotherapy option as a poor option in these patients. So I fully agree with you with the fact that disease-free survival could be a very suitable endpoint for setting newer standards, but we should still be cautious, waiting for and pending the hazard ratios and the results from long-term OS.
Yeah, no, I couldn't agree more. I think it's always complicated when we have these endpoints. They're obviously endpoints that are discussed and accepted by the regulatory agencies, but obviously we want to see that there's ultimately a benefit in survival outcomes for our patients. There's a nice question that speaks to sort of the logistical features that are required for sort of integrating or bridging urology clinics and oncology clinics, particularly with all of the new agents that are sort of across many disease stages that were not sort of traditionally used and are being used now. So, I sort of spoke to what we do at the University of North Carolina at Chapel Hill. There are actually some of my colleagues in the audience. We have a nurse practitioner who's in the audience, Mary Dunn, who works closely in a survivorship capacity with our patients as well. So we have a really integrated group that works closely together to provide that level of multidisciplinary care. I'll turn it to both of you just to maybe describe what happens in the context of your clinics. Dr. Gupta?
Yeah, we don't have a multidisciplinary like you described, Matt, but the best we do at a multidisciplinary is if a urologist sees a patient and wants us to see the patient the same day, we see the patient. But I think we still underutilize bladder preservation a lot, like a lot of other centers, and I think ideally we should be, the three specialties should be seeing the patient together.
Dr. Necki.
Yeah, I can tell you that my experience in developing neoadjuvant immunotherapy in patients with muscle-invasive disease was an educational path, an educational journey that benefited both of the sides of medical oncology part and urology part. Urologists became much more experienced in managing internal medicine side effects that occurred in the perioperative space. We grew our experience in managing patients treated with novel therapies perioperatively, trying to identify, for example, the safety issues of the delay in cystectomy, which is a critical issue, maybe a critical issue to consider as a safety issue when developing any newer therapies in patients with a potentially curable disease, with a curable option. And lastly, I would say for the next generation physician and investigators, moving towards a multidisciplinary management and testing newer therapies in early disease setting and working together with other specialists is an outstanding opportunity for building careers and for building an opportunity to develop a career in bladder cancer. So the model of developing in a multidisciplinary way newer therapies is a very, very well suited model for many, many reasons.
Thank you. I'll frame this next question. So I don't know about all of you, but I think I walked out of the prostate sessions today even more confused than I was before about the use of PARP inhibitors and DDR alterations, et cetera. So, we know the Memorial Group, as an example, has published data with regard to DDR alterations, germline alterations. We know the genomic alterations, the somatic alterations that exist within DNA damage repair genes. So this question says, what options are available for that patient that comes in the door? What do you do for a patient who has a DNA damage repair gene alteration, somatic or germline? Dr. Gupta?
So the good news is there are a lot of trials for patients with localized disease. For example, in the Alliance, we have the trial where if patients have DDR alterations and they get a good response to cisplatin-based chemotherapy, they have the chance to preserve their bladder. So for a localized bladder cancer patient, I would certainly encourage enrolling on trials. And for metastatic setting, we still don't know if PARP inhibitors are a very relevant agent because, just having the DDR alteration, we've not seen fantastic results from PARP inhibitors, so we still need to learn more.
Yeah, Dr. Necki, I mean, the other thing I would just pose to you is there have been some particular DDR alterations that appear to potentially confer a benefit to, neoadjuvant cisplatin-based combination chemotherapy like ERCC2, ATM, FANCS, et cetera. We saw in prostate cancer today, it looks like ATM is perhaps not so good. Thoughts in bladder cancer?
Yeah, my thought is basically is very practical. Is based on the fact that we have too limited information regarding the potential role of HRR gene alteration in determining higher chances of responding to PARP inhibitors, or the frequency is too low to justify an extensive use outside of clinical trials in order to identify a potential germline mutation of germline nature that may justify a genetic counseling for a selected patient. So the numbers are very small at the end. So moving outside of clinical trials with HRR gene alteration or PARP inhibitors seem to be quite or extremely hard in this disease, where at the very beginning of the path, maybe as Shipta has already mentioned, the use of HRR gene alteration is pretty much suited for alternative treatment selection like standard cisplatin chemotherapy or immunotherapy rather than targeted approach with PARP inhibitors.
Yeah, and I guess, one other question that certainly relates to this is when we think about germline DDR alterations, again, there's been more emerging data. What sort of family history is important to you when you're seeing a patient in the clinic? A follow-up to that would be in patients with upper tract urothelial cancer, where we know that there's a higher prevalence of particular alterations. Are those patients that, for example, you're doing MMR protein by IHC, et cetera? Dr. Gupta?
So for a patient with DDR, germline alterations, we should take a thorough family history for pancreatic cancer, breast cancer, and really refer to a genetics counselor. We do have that availability at our clinic, for genetic counseling. So that's a really good thing we should use more of. And for upper tract disease, patients with Lynch syndrome can have MSI-high disease, and that we know would be responsive to immunotherapy as opposed to those usually we know in upper tract immunotherapy may not work well. So I think at the end of the day, genetics counseling needs to become a part of our multidisciplinary care.
Yeah. Dr. Necki?
Yeah, I fully agree with previous consideration. Of course, if you have a report of BRCA1 or 2 genomic alteration, somatic alteration in the tumor of a bladder cancer patient, of course, and a hint towards genetic counseling of the family of this patient should be provided. But besides this very special situation that are occurring very, very infrequently in general in the management of these patients, we should be stick to the indication that Shilpa has already provided.
So I think we're out of time. I want to thank Dr. Necki and Dr. Gupta for excellent discussions. Thank you all for your attention. Good night.
Thank you.
Thank you.
Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/KPE 860. This activity is supported through independent educational grants from AstraZeneca, Bristol Myers Squibb, and Janssen Biotech Incorporated, administered by Janssen Scientific Affairs, LLC.